জি, আসসালামু আলাইকুম স্যার। স্যার আপনি লাইভে চলে
হ্যাঁ
আসছেন, শুরু করতে পারেন।
ঠিক আছে, থ্যাংক ইউ। Can I start the class right now? Muntasir or Nafisa?
Yes, sir.
Riyad? Okay, let's
Yes,
start
sir.
the class. Okay, thank you. Okay, let's start the class. Today's topic will be on the drugs in physical medicine and rehabilitation. Okay, I'm going to share the screen. Can you see the screen clearly? Riyad?
Yes, sir.
Okay, thank you.
Thank you so much.
So today's topic will be on the drugs in physical medicine and rehabilitation. First of all, I would like to introduce myself. I'm Dr. Mohammed Ilyas. I'm an associate professor of physical medicine department of USTCB BMH. Okay, let's start the class. Before going for the whole details about the drugs in physical medicine, actually, we should know something about the patient loads of our physical medicine department. Whenever we can have some idea about the patient loads of the physical medicine department, at that time we can have some idea of the importance of knowing the drugs in the physical medicine department as well. And if we can understand actually how many patients are there with the pain, how many patients are there with the neurological conditions, and how many patients are there with other causes, so that time we can have the importance of knowing the drugs in the physical medicine. Actually, the patient, those who come to our department, they actually mostly come with the pain. And approximately 80 to 85% of the patients of our physical medicine department come with the pain. And the 15% of the patients, those who come to our department, actually come with the neurological conditions, like the cardiovascular diseases in the form of the stroke or any other accidents, like the root of accident having the cardiovascular incident in the brain, or sometimes few patients come with the radiculopathy or enterocolitis as well. So these are the patients with the neurological conditions, amounts for 15% of the total cost. And 5% of the patients in our department come with other causes to take the service for the rehabilitation purpose, with the cause of the myopathy, with the cause of muscular dystrophy or the burn, or the stiffness due to the fracture or any other primary causes, or after removal of the plaster as well. And the cardiovascular system pathologies, like a patient is undergoing the bypass surgery, that time the patient must have to have some rehabilitation procedure to have the total fitness from the cardiovascular diseases. And other patients come with the respiratory complaint, and they must have to undergo the rehabilitation procedures. Otherwise, the patient might not have the total fitness from the respiratory problems. So these are the patients come with other causes. And sometimes few patients come with the orthopedic conditions for the rehabilitation purpose. So all these causes actually come to our department with these kind of conditions. But mostly we face the patients with the pain. And before going to know the drugs, actually we should know the what kinds of pain we face in our department. Among all the pain, those who come to our department, actually we get two kinds of pain. Number one is the mechanical pain, and another one is the inflammatory pain. You know, the mechanical pain, the pain which comes with the mechanical activities or overuse syndrome of any of the part of the body, or any kind of stressful job. Whenever the patient will be having these kind of conditions, the patient will have the pain. And this is the feature of the mechanical pain. And whenever the patient will alleviate the stress over the joint, will remove the stress over the joint or any of the body part of the body, so that time the patient will get relief from the pain. So that is the feature of the mechanical pain. And actually we get this kind of pain in case of the lumbar strain or any kind of the trivial injury or any kind of stressful job, or if you think of the osteoarthritis or the geriatric problem. So these kind of patients will be having the mechanical pain. Okay, and definitely after having the resting condition or after removing the stressful activities from his body part, so that time the patient will get relief from the pain. So these are the features of the mechanical pain. And among all the pains, actually 60 to 75% of the patients come with the mechanical pain. And rest of the patients that will account for 30 to 35% of the total causes come with the inflammatory pain. You know, the inflammatory pain comes with the resting condition, or whenever the patient goes for the nighttime sleep, that time in the late part of the nighttime sleep, that pain will be of so extreme level, and the patient will feel pain after doing some resting condition. And whenever the patient will get up from sleep, that time the patient will feel the most pain, and the pain will go off after doing some mechanical activities. Whenever the patient will be going for the movement from here to there, the pain will go off. So these are the features of the inflammatory pain. And after having the overnight resting condition, actually why the patient will feel the pain in case of the inflammation? Because due to the resting condition, actually during the overnight resting condition, the patient won't be having any kind of movement of the joint. As a consequence, the patient won't be having any kind of movement of the muscle as well. So the patient won't be having any kind of pumping activity of the muscle. So due to the loss of the pumping activities of the muscle, of the joint. Ultimately, the pumping effect of the blood circulation won't be there. So ultimately, the venous stasis or the blood stasis will be there over the inflamed part of the joint, or over the inflamed part of any structure of the body. So as a consequence, there will be deposition of the exudates and inflammatory cytokines and interleukins throughout the night or throughout the resting condition. So ultimately, whenever the deposition will be high enough, ultimately, and in the last part of the resting condition, the exudation will be in extreme condition and the pain will be with the severity. So that time the patient will feel the pain. And whenever the patient will go for the movement of the joint, so ultimately the contraction and relaxation of the muscle will be there. So pumping effect of the blood vessel will be there. So the new blood will come inside. The old stored blood will be washed away, will be drained out by the venous drainage. So ultimately, the patient won't have any kind of deposition of the interleukins and cytokines that will produce the inflammation. So ultimately, the pain will go off. So these are the features of the inflammatory pain and the pathology behind this. So uh, I think this is clear for you that what is the mechanical pain and what is inflammatory pain. Actually, it should be discussed very clearly to know the importance of the pain reduction, because most of the patients, those who come to our department, come with the pain mostly. So that's why before going to discuss all other drugs in the physical medicine department, actually we should give emphasis on the analgesics mostly. That's why I mentioned the name of the analgesics above all other drugs. Okay, let's come to the next slide. You see, I mentioned here the drugs in physical medicine and rehabilitation. First of all, I mentioned the name of the analgesics. You know, the analgesics means the drugs which will be active to reduce down the pain against the algia, against the pain. This will be active. Okay, I will discuss these things. How many types of analgesics will be there, I will discuss in the next subsequent slides later on. And later I discussed over here, I mentioned the name of the anti-ulcerant. You know, whenever we will prescribe the analgesic to the patient, especially whenever we will give the anesthetic to the patient, so there will be some chance of having some kind of gastritis or peptic ulcer disease. So that time we must have to prescribe the anti-ulcerant, that is in the form of the pressure groups, that is the omeprazole, esomeprazole, dexlansoprazole, lots of things are there. So this is also very important things along with the analgesics. And in the third part, I mentioned the name of the muscle relaxants. Why the muscle relaxants are also needed for reducing down the pain. Especially, we prescribe these muscle relaxants for the pain of the low back area, for the pain of the neck region, or any kind of muscular pain. Because whenever the patient will be having the low back pain, or whenever the patient will be having the neck pain, that time the patient will be having some kind of spasm of the muscle. So due to the spasm of the muscle, ultimately there will be some kind of stasis of the blood, because there will be some shrinkage of the total composition of the muscle. So as a consequence, no new blood can't come inside the muscle, and no old blood can't go outside due to the spasm, due to the constriction of the vessels. So ultimately, what happens, the old stored blood will be utilized to have the metabolism of the muscle, to have the ATP formation of the muscle, and whenever the old stored blood you will be utilized for the aerobic glycolysis, that is whenever the oxygen will be utilized for the aerobic glycolysis, ultimately the oxygen composition will be less inside the muscle due to the utilization of the oxygen. So as a consequence, there will be hypoxemia, that is oxygen content will be less within the muscle. So as a consequence, the muscle, that muscle will start the utilization of the anaerobic glycolysis. Okay, so as a consequence of anaerobic glycolysis, you know, the byproduct will be the lactic acid, and that lactic acid is the irritant substance for the muscles. So as a consequence of the anaerobic glycolysis, whenever there will be the muscle spasm, the patient will be having the irritation of the muscle, and as a consequence, the patient will have the pain due to the lactic acid formation. So until and unless you go for the relaxation or total relaxation of the muscle, uh, along with the prescription of the NSAID, actually the patient won't get 100% relief from the pain. So whatever analgesics you are prescribing, in case of the muscle spasm, in case of the lumbar strain or any kind of sprain, so that time if you don't prescribe the muscle relaxant, actually the patient won't get 100% relief from the pain even after prescribing the NSAIDs. So this is also very important things for reduction of the muscle pain. Okay, and now fourth one is the neurovitamins. You know, earlier I told you about the neurological patients. The patients come to our department with the neurological complaint. Say a patient is having the intrapatient neuropathy, a patient is having the peripheral neuropathy, a patient is having the stroke. So in these cases, to have the recovery from this kind of neurological condition, along with prescribing other drugs, we must have to prescribe the neurovitamins. Actually, without prescribing the neurovitamins, we can't have the total regeneration or the neuronal spotting or the neuronal spasticity, neurospasticity of the brain without prescribing these drugs. So these drugs actually must be prescribed to this kind of patients. We prescribe the neurovitamins in the form of the vitamin B, vitamin B1, B6, and B12, or sometimes we prescribe the alpha lipoic acid. These alpha lipoic acid work like the antioxidant of the neurons. Whenever there will be damage of the myelin sheath, whenever there will be compression producing the damage of the sensory part of the neurons, or whenever there will be damage of the motor part of the neurons, so ultimately there will be various kinds of destruction within the neurons. So to recover this kind of destruction, we must have to prescribe the alpha lipoic acid. That is one kind of essential fatty acid. Whenever we will prescribe this kind of alpha lipoic acid along with the neurovitamins, actually the regeneration of the neurons will be much more. And especially this kind of vitamins should be prescribed for the dementia, in which the patient will be having the memory loss or the amnesia, or sometimes we prescribe this kind of neurovitamins for the anti-pain neuropathies, or in case of the stroke patients, we must have to prescribe this kind of diseases, this kind of drugs. So these are the importance of the neurovitamins. If you think of the nutraceuticals, you see in the fifth part, I mentioned the names of the nutraceuticals. Whenever the patient is having the degenerative process of the joints, so ultimately the patient will be having the erosion of the cartilage. To counteract the further progression of the erosion of the cartilage, we must have to prescribe some drugs. These are called as the nutraceuticals. Among the nutraceuticals, we prescribe the glucosamine sulfate, chondroitin sulfate, and sometimes we prescribe the calcium orotate also as the nutraceuticals. And sometimes we prescribe the proloxin in the form of the ozone and the dextrose. These are also helpful for the nutraceuticals activities. And sometimes we prescribe the hyaluronic acid. Okay, this hyaluronic acid is one of the composition of the synovial fluid. And sometimes we prescribe the undenatured type 2 collagen. These things are the nutraceuticals, and these are very much helpful in prevent the early progression of the degenerative joint diseases, especially in the osteoarthritis of the knee joint or osteoarthritis of any of the joints, or even in case of the erosion of any kind of inflammatory arthropathy, we may prescribe this kind of nutraceuticals. Okay, and last of all, I mentioned over here the membrane stabilizers. Actually, these are mostly known as the anticonvulsant drugs. We know the anticonvulsant drugs. There are lots of anticonvulsant drugs, but mostly we prescribe the carbamazepine, we prescribe the pregabalin, gabapentin, or sometimes we prescribe the clonazepam. Actually, these drugs actually prevent the transmission of the acetylcholine from the presynaptic nerve terminal to the postsynaptic ones. So ultimately, what happens if a patient is having the neuropathic pain? So what happens in case of neuropathic pain? We know the neuropathic pain is caused by the transmission of the unwanted neuronal stimulation by the acetylcholine transmission from the presynaptic one to the postsynaptic ones. So ultimately, likewise, the transmission of the neuronal stimulation will be there by the transmission of the acetylcholine. But the membrane stabilizer actually prevent the transmission of the presynaptic nerve terminal acetylcholine to the postsynaptic nerves. So likewise, this will prevent the progression of the stimulation, which is the unwanted stimulation of the neurons. So these kind of membrane stabilizers can be prescribed to prevent or to treat the neuropathic pain, and which are very common in case of lumbar radiculopathy, or sometimes we get the carpal tunnel syndrome patients. So in this case, the patient will be having the abdominal sensation, that is the paresthesia, numbness, and these are very much irritating for the patient. To counteract this kind of irritating sensation, we should prescribe this kind of membrane stabilizers. So in a nutshell, actually, I wanted to describe these things, the drugs that we prescribe in our physical medicine department. Okay, I'm going to the next slides. That will be helpful for your better understanding. You see, what is analgesics? Okay, let me have some water. I mentioned over here the types of the analgesics. Mostly we prescribe the NSAID, flatly speaking. Whenever a patient is coming to us, we try to prescribe the NSAIDs mostly, because NSAID are very easily available drugs, and other than having the kidney problems, other than having the liver or the heart problems or the gastritis, actually there are less chance of having other side effects, because that will, if the patient is having the existing kidney disease or any kind of existing liver disease in the form of the CLD or the hepatic failure, or if the patient is having the ischemic heart disease or having any kind of previous history of the angina or any kind of previous history of the CABT, coronary arterial bypass surgery. So that time we should better to avoid the NSAIDs. So in these cases, we might prescribe the non-steroidal anti-inflammatory drugs, but there are also some selection. Not all drugs can't be prescribed flatly for this kind of diseases. So in that case, we should prescribe the non-NSAID drugs. And these are not harmful like the NSAIDs in the perspective of the kidney disease, in the perspective of the liver disease or the heart diseases. So these drugs are available in two forms, in the form of the opioids. You know, the morphine and pethidines are there. And another one is the opioid-like analgesics. These are found in our Bangladesh in the form of the tramadol or the nalbuphine. But the problem is that though these are not doing doing harm to the kidney, liver, or the heart, but still it does have some very aggressive stimulatory effect on the chemoreceptor zone. So sometimes the patient might be having some kind of vertigo, or sometimes this could be uncontrolled vertigo, or sometimes the patient might be having the emesis, and it can't ever be stopped even after prescribing the antiemetic drugs. So that time we should better avoid this kind of non-NSAID drugs. Okay, this is the flat subtypes of the analgesics, that is the NSAID and the non-NSAID. Actually, you studied all the things in fourth year in the pharmacology courses. So actually, this is not the concern with me. I'm just going to highlight all these things before going for the main discussion. So you see how the NSAID will be producing the kidney disease. Actually, whenever the patient will be having the pre-existing kidney disease, that time the NSAID will aggravate the kidney problems, mind it. Whenever the patient will be having the renal arterial stenosis due to any kind of problem or any kind of hypertensive condition or any kind of diabetic problems, so that time the patient will be having the decreased blood flow to the kidney due to the stenosis, renal arterial stenosis. So, as a consequence, to maintain the normal homeostatic mechanism, kidney tries to produce the prostaglandins. These are the renoprotective prostaglandins. Okay, and as a consequence, this renoprotective prostaglandin will increase the blood flow to maintain the homeostatic mechanism. But what happens in case of the NSAID? In case of this decreased blood flow, that is the hypoxic condition of the kidney, if we prescribe the NSAID, ultimately this NSAID will interrupt the formation of the renoprotective prostaglandin. So as a consequence, the kidney itself can't maintain the homeostasis due to the interruption of the formation of the renoprotective prostaglandin. So as a consequence, the patient will be having the more aggravation of the kidney problems. So that's why the pre-existing kidney disease patient should not be prescribed the NSAIDs. Okay, so this is very basic primary pathology of the causation of the kidney impairment in case of the pre-existing kidney diseases. So that is very important thing for you. Okay, so you see I mentioned over here how the NSAIDs will be working in our body, how these are reducing down the pain and inflammation, how these are actually interrupting the hemostatic mechanism, and how they will produce the gastric mucosal irritation. All these things are described over here in nutshell, but I am not going to discuss this because you studied all these things in the 4th year and the 3rd year in the pharmacology course. Okay. So you see, this is a very basic classification of the NSAID. I'm not going to discuss these things because you studied all these things. You see how the, and what is the more safer NSAID for the cardiovascular disease. Mostly topical NSAID, if it can be prescribed to the patient, that is far safer so for the cardiovascular system safety. But among all other NSAIDs, whenever this can be, should be prescribed orally or in the parenteral form, naproxen and ibuprofen are safer so NSAID. So this will be having less side effect on the cardiovascular system. But the toxic groups drugs, that is the drugs which are the COX-2 selective NSAIDs, these will be having highest risk for the cardiovascular system. Or if you think of the diclofenac, or if you think of the ketorolac, this will be having the highest risk to produce the cardiovascular risk. Okay, so I'm going to the next slide. So you see, this is the diagram showing the NSAID action, how this work to reduce down the pain, how this work to cause the gastrointestinal mucosal irritation. I'm not going to discuss these things. And you see, another thing is that what kind of risk factors will be associated with the GI bleeding along with the prescription of the NSAIDs. Whenever we'll be prescribing the NSAID along with this kind of risk factors, the patient will be having the chance of the GI bleeding. If the patient is having the age of more than 65 years, or if the patient is taking the long-term oral NSAID, or if the patient is having any kind of previous history of GI bleeding, or any kind of previous ulcer or H. pylori infection. So in these cases, the patient will be having some chances of having the GI bleeding. And if the patient is having any kind of history of previous heavy smoking or any kind of previous history of alcohol drinking. So in these cases, the patient will be having some chance of the GI bleeding with the concomitant intake of the NSAIDs. So whenever we will be getting this kind of risk factors for the patient, better to avoid the prescription of the NSAID. Otherwise, the patient will be having this kind of side effects in the form of the gastromucosal bleeding, or the patient could be having some kind of hematemesis or the melena, or sometimes the patient might be having coming having some history of hemoptysis. So these are very important things. So whenever we will be getting this kind of risk factors to the patient, we better try to avoid this kind of prescription of the NSAIDs. Okay. So these are very basic things. I think by this time, you know all these things from your 4th year pharmacology classes. So up to this, actually, these are not my concern. Okay. Up to this, but from now on, the concern things of the NSAID, which will be much more related for our department, that is the NSAID types, according to the potency and according to the preference. What is the meaning of the potency? You know from your background knowledge of the potency, potency means the strength of the NSAID. The more the potency of the NSAID, the more the strength of the NSAID, the more the activity of the NSAID to reduce down the pain then and there. Okay, but whenever the patient will be having the more potent NSAID, this more potent NSAID will be much more active in reducing down the pain. So in this relation, we should mention about the severity of the pain. If the patient is having the severe pain, we must have to prescribe the most potent or more potent NSAID. Okay, but whenever the patient will be having the mild to moderate pain, we may prescribe the less potent or the least potent NSAID. So if a patient comes to you with the history of the road traffic accident or with a history of any kind of trauma, so that time the patient might be having so much complaint of severe pain. So that time, to be just in prescribing the NSAID, you must have to prescribe the more potent or the most potent NSAID. Without prescribing the more potent or most potent NSAID, actually, you can reduce down the pain very promptly for that case. On the other hand, if the patient is having the less pain due to the trivial injury, so that time you can prescribe the less potent NSAID. Okay, I'm going to discuss these things later on about the potency. And another thing is the NSAID types according to the
স্যার আসসালামু আলাইকুম।
ওয়ালাইকুম সালাম। হ্যাঁ
স্যার আপনার একটু মানে সাইড সাউন্ড হচ্ছে, স্যার যদি একটু দেখতেন।
ও আচ্ছা আচ্ছা ঠিক আছে, থ্যাংক ইউ, আমি একটু করছি।
জি স্যার,
জাস্ট হোল্ড অন, থ্যাংক ইউ। Okay, sorry for the interruption. Actually, my kid was crying. Okay, so now I'm discussing the NSAID types according to the potency and the preference. So earlier I told you about the potency. So whenever the patient will be having the severe pain, we must have to prescribe the most potent NSAID. And another type is the NSAID type according to the preference. Say a patient is having the peptic ulcer disease, a patient is having the respiratory problem, a patient is having the osteoarthritis of the joint. So in this case, all kinds of NSAID actually won't be that much equally effective to reduce down the pain. So in this case, we must have to be selective in selecting the NSAID, because definitely after prescribing the NSAID, the patient will get the support to reduce down the pain. But whenever we'll be selective in preferring the NSAID, that time the patient will get the benefit, extra benefit other than reduction of the pain. I will go to discuss these things later on. So these two types of NSAIDs are very important for managing the patients of the physical medicine. And from now on, actually, the discussion will be oriented with the physical medicine in relieving the pain by prescribing the NSAIDs. So these are very important things for you. Try to be attentive whenever I will be discussing these things, and try to be attentive on this. Okay. you see, if you think of, okay, okay. So first of all, I'm going to discuss the potency of the NSAID. Till now, almost 20 to 25 numbers of NSAIDs have been invented. Okay, among all these NSAIDs, the ketorolac is the most potent one. Okay, so if we actually stratify this ketorolac along with the other NSAIDs, we can understand the strength of the ketorolac, how much stronger the ketorolac is than other NSAIDs. It is established after doing one study, actually, that is ketorolac is 5 times more potent than diclofenac, mind it, and 6 times more potent than aceclofenac, 7 times more potent than indomethacin, mind it, 10 times more potent than etoricoxib and the ibuprofen, okay, and 15 times more potent than meloxicam, 50 times more potent than naproxen, and 350 times more potent than aspirin. Actually, this table is very important for you. So you see, up to the etoricoxib, we can think of the two most potent NSAIDs. Okay, so ketorolac is the most potent NSAID up to the etoricoxib and indomethacin. These are the more potent NSAID. After these things, these are the less or the least potent NSAID. So among all the NSAIDs, aspirin is the least potent one. And the ibuprofen, meloxicam, and naproxen, these are the least potent NSAIDs. And the etoricoxib or the ibuprofen, these are the moderate potent NSAID or the potent NSAID. And the aceclofenac, indomethacin, these are also the potent NSAID. And the most potent NSAID are the ketorolac and the diclofenac. So mind it. So if a person comes to you with the severe pain, with the road traffic accident, with the history of the fracture, and the patient is screaming out of pain, so that time we must have to prescribe the ketorolac or the diclofenac, mind it. Okay. But if a patient comes to you with a very trivial pain, the patient can maintain his day-to-day life activities with the pain. So that time, definitely the patient is having the mild to moderate pain. We can treat this case with the potent or the moderate potent or the least potent NSAIDs. That is ibuprofen, meloxicam, naproxen can be prescribed to this kind of patients. So the more the severity of the pain, you must have to think of the most potent or the more potent NSAIDs. If the patient is having the trivial pain, with a very less potency, less severity, so that time we can prescribe the less potent NSAID. Okay, that is in the form of the naproxen. Even the aspirin can be active in reducing down the pain. So this slide is very important for you. The potency must be counted in treating the severity of the patient. But another very important issue is that the more the potency of the NSAID, the more the harm to the patient, mind it. And if you think of the cardiac safety, better to avoid the more or most potent NSAIDs. Okay, we may think of the naproxen, and the naproxen, pure naproxen, is the safest NSAID for the cardiovascular safety. Okay, so this slide, I think, if you can have the idea about this slide, you can think of the very just treatment for the severity of the pain. Okay. You see, now I am going to discuss the preference of the NSAID. You see, I mentioned over here some of the issues in the peptic ulcer disease, in the renal impairment, in the cardiac problems, okay, in the respiratory problems, in the degenerative joint diseases, in the inflammatory arthropathy, in the gout. So all these things are very important. Say a patient is having the pain, but the patient is having the peptic ulcer disease. So we'll be having some problems in prescribing the drugs, because we know from our background knowledge of pharmacology that NSAID will cause the bleeding or will cause the ulceration in the gastric mucosa. So in prescribing the NSAID, in case of the patients of the pain along with the peptic ulcer disease, we must be choosy. We must have the preference in selecting the NSAIDs. So you know from the background knowledge of pharmacology, COX-2 selective NSAIDs are far safer for the peptic ulcer disease. So these cost-to-selective NSAIDs, you know, are the valdicoxib, celecoxib, rofecoxib, etocoxib. In our Bangladesh, the etocoxibs are available, but rest of the coxibs are not available in our Bangladesh. And another NSAID that is not actually the COX-2 selective NSAID, that is actually non-selective NSAID, but still it does have one unique property that will produce the lipoxin, that is the acetaminophen. These NSAID definitely will be helpful in reducing down the pain, but as a byproduct, the lipoxin is produced from the acetaminophen metabolism, and that lipoxin is helpful in formation of the mucin from the gastric mucosa, and that lipoxin will stimulate the formation of the mucin from the gastric mucosa. So as a consequence, actually, it doesn't have any harmful effect on the gastric mucosa, and it doesn't cause any kind of gastric irritation. So those those who are having the pain along with the peptic ulcer disease, we can prescribe the acetaminophen or the COX-2 selectives. Me personally actually prescribe the acetaminophen because COX-2 selective NSAIDs, it does have some kind of side effects like this will retain the fluid, and moreover, if the patient is having the cardiovascular problem, we can't prescribe the COX-2 selective NSAID. So in that case, acetaminophen is a drug of choice for me myself. Okay, I think you can better prescribe the acetaminophen for the peptic ulcer disease. Okay, and another issue is that a patient is having the pain along with the renal impairment. So flatly, actually, first of all, we will tell no NSAIDs should be prescribed for the renal impaired patient. But if still anybody asks you about the laxity of prescribing the NSAIDs for this kind of renal impaired patient, and where we can't reduce down the pain other than prescribing the NSAID in case of renal impairment, if anybody asks you about the knowledge of these things, you can tell the sulindac and nabumetan. These two drugs can be prescribed for reducing down the pain in case of renal impairment up to the stage 3 of the renal impairment disease. You see, actually, what the sulindac and nabumetan do have for the special criteria. Actually, earlier I think I showed, yes, I showed you here. You see this NSAID, sorry, over here, NSAID will interrupt in the formation of the rhinoprotective prostaglandin, but the nabumetan and the sulindac won't have any kind of interruptive effect on production of the prostaglandin, that is the rhinoprotective prostaglandin. So up to the stage 3 of the renal impairment, we can prescribe the sulindac and the nabumetan. Okay. So if anybody asks you about your knowledge of the NSAID which can be prescribed for the renal impairment patient, you can tell the sulindac and the nabumetan are safe for the renal impaired patient up to stage 3. So this is very important things. Okay, so I think it is clear up to this. And in cardiac problems, say a patient is having the previous history of the heart failure, a patient is having the previous history of unstable angina, or a patient is having the muscle weakness of the heart, or the patient is having the cardiomyopathy. So in this case, all kinds of NSAIDs should be avoided, but the pure naproxen, not the naproxen sodium. There are two types of naproxen. Number one is the pure naproxen without the sodium, and another naproxen is the naproxen sodium. Pure naproxen is safe for the cardiac patient because it doesn't have any fluid retaining capability from the distal convoluted tubule. So ultimately, these pure naproxen won't increase the afterload of the heart. So in case of heart failure or in case of cardiomyopathy patient, you can prescribe the naproxen, where the prescription of the NSAID is mandatory. Okay, so pure naproxen can be safely prescribed to the cardiac patients. Okay, I am going to the next slide. Okay, another very important thing is that NSAIDs in the CLD, that is chronic liver disease. Earlier, I told you the NSAID might cause the hepatic problem. So in case of pre-existing hepatic problem, we should not prescribe the NSAID, better to avoid this kind of NSAID. And in case of advanced CLD, not even the paracetamol. In case of early CLD, we can prescribe the paracetamol that can be safely prescribed to the patient of the pain. But in case of advanced CLD patient, we can't even prescribe the paracetamol. Actually, why the paracetamol can't be prescribed for the advanced CLD patient? You know from your background knowledge of pharmacology, as a byproduct of the paracetamol, the NAPQ1 is produced for the from the metabolism of the paracetamol, and NAPQ1 means N-acetyl parabenzoquinone, and which is hepatotoxic. In the normal hepatic status, this NAPQ1 is detoxified by the formation of the DL-methionine, which is produced by the normal hepatocyte. But whenever the patient is having the CLD, whenever the hepatocytic activities will be compromised, so no DL-methionine will be produced properly. So ultimately, this NPQ1 will cause more harm to the hepatocyte. So ultimately, the paracetamol by the NPQ1 will cause the hepatotoxicity. So in case of advanced CLD, we should not prescribe the paracetamol. Okay, I'm going to the next slide. And you see other issues are there in the respiratory problems. You know the respiratory problems, if we think of the COPD or the COAD, or if you think of the chronic bronchial asthma. In this case, COX-1 and COX-2 non-selective NSAIDs should be avoided. In that case, the COX-2 selective NSAIDs can be prescribed, or opioid-like analgesics, or even the paracetamol can be prescribed to the patient. Okay, because the COX-1 and COX-2 non-selective NSAID will interrupt in the bronchodilating prostaglandin formation, but the COX-2 selective NSAID won't do this kind of effect on the bronchus. So this can be prescribed for the chronic COPD or the chronic bronchial asthma patient. Okay, if you think of the degenerative joint diseases, you know the degenerative joint diseases are found in the patients of the physical medicine department in the form of the osteoarthritis or any kind of erosive arthritis, say in the form of the rheumatoid arthritis. So these are the degenerative joint diseases that might be associated with the genetic problems. So in this case, definitely prescribing all kinds of NSAID will be helpful in reducing down the pain. Okay, but if we prescribe the aceclofenac or the tanoxicam, we can get extra additive supportive effect on the damaged joint other than reduction of the pain, because the aceclofenac helps in the formation of the cartilage synthesizing enzyme, because it will be helpful in the activities of the cartilage synthesizing enzyme. So those who are having the osteoarthritis where the cartilage destruction is there, if we prescribe the other NSAIDs like the etirocoxib or the indomethacin or the naproxen, these NSAID can be helpful in reducing down the pain. But if we prescribe the aceclofenac, definitely this will also reduce down the pain along with the regeneration of the cartilage due to the stimulatory effect on the cartilage synthesizing enzyme. I think it is clear to you. And another thing is that tanoxicam is helpful in preventing the degradation of the cartilage by preventing the activities of cartilage destructing enzyme. So both these kinds of NSAID, that is the aceclofenac and the tanoxicam, definitely this will reduce down the pain along with the preservation of the cartilage. But avoiding these two NSAIDs, if we prescribe other NSAIDs, definitely this will also reduce down the pain, but we can't get that kind of cartilage preservating activities of the NSAIDs. So better to prescribe this kind of aceclofenac and the tanoxicam in the degenerative joint diseases. So I think it is clear to you. But in that relation, we should know that there are 3 NSAIDs which are helpful in degradation of the cartilage. These are the naproxen, these are the etirocoxib, and another one is the indomethacin. though this will reduce down the pain, but this will be having some kind of deleterious effect on distracting the cartilage in the joint. So whenever a patient is coming to you with the degenerative joint diseases, we should prescribe the aceclofenac or the tanoxicam to reduce down the pain, because we'll be getting extra benefit other than reducing down the pain. But if we prescribe the etocoxib, if we prescribe the indomethacin, or if we prescribe the naproxen unknowingly, actually that will be having some bad effect on the cartilage, though this will reduce down the pain. Okay, I think it is clear to you. And another thing is the inflammatory arthropathies. You know, the inflammatory arthropathies we get in the rheumatoid arthritis, in the spondyloarthropathies. So these are the inflammatory arthropathies. So these inflammatory arthropathies can be very promptly managed by the indomethacin. Actually, this indomethacin does have some immunomodulatory effect, because this immunomodulatory effect this by the immunomodulation, this indomethacin can actually prevent the early progression of the inflammatory disease process. So that's why indomethacin should be prescribed for the inflammatory arthropathies, say in case of rheumatoid arthritis or in case of spondyloarthropathies. So these kind of diseases should be treated with the indomethacin. Though we do have some other option, that is the aceclofenac or the tanoxicam or the corticosteroid acid, but still, if we prescribe the indomethacin, we will get the extra benefit other than reduction of the pain. I think it is clear to you. And another issue is the gout. What's about the gout? You know, the gout happens due to the uric acid deposition within the joint and causing the inflammatory reaction within the joint. And with the gout, the patient will be having so severe pain ever in life. After taking the history from the patient of the gout, you can easily diagnose the disease. And for the gout, whenever the gout will be having the pain along with the hyperuricemia, that time the preferred option will be the etodolac, because the etodolac will be helpful in reducing down the pain along with lowering the uric acid level from the blood. You might ask me that other drugs can also be prescribed definitely to reduce down the pain, but along with reduction of the pain, we want to get some extra benefit from the drug, that is the etodolac. So if we prescribe the etodolac in the gout, we will get two benefits. Number one is the reduction of the pain. Along with this, we can get some benefit to reduce down the uric acid level. So I think this slide is clear to you. I'm going to the next slide. So you see, here I mentioned about the NSAIDs in the kidney safety. Whenever the patient comes to us with the chronic intake of the NSAID, so in that case, we must have to be attentive. We must have to be concerned with the kidney safety. Otherwise, we may put the patient into more danger by prescribing the NSAID. Okay. So far, the nabumetan and the sulindac are the safer NSAID in the kidney disease of stage 3. But after stage 3, that is stage 4 and stage 5 kidney disease, actually we should also avoid the nabumetan and sulindac. Okay. And next comes the name of the tanoxicam in case of the safety of the kidney disease. Okay. And next comes the name of the diclofenac. And next comes the name of the naproxen, indomethacin, ketorolac, and ibuprofen. So the most harmful drug for the kidney is the ibuprofen, mind it. But for the kidney, for the livers, for the cardiac safety, the ibuprofen and the naproxen are safer drug among all the NSAIDs. So, but from this slide, we can easily understand that ibuprofen and the ketorolac, these are the most harmful drug for the kidney. And the safer drug for the kidney among the NSAIDs are the nabumetan, sulindac, and the tanoxicam. And this can be prescribed, especially for the tanoxicam, it is told that it can be prescribed for the normal patient for up to 5 to 7 years. So these are very important things for you. I think you can note it down. Actually, what are the kidney safe NSAIDs? Okay. Okay, I'm going to the next slide. There are some informations about the ketorolac. Ketorolac can be given for the CABG patient. CABG means coronary arterial bypass surgery, bypass grafting. So in case of the CABG patient, we should avoid the ketorolac. Okay. Or if the patient is having the age of less than 70 years, so that time we should not prescribe the ketorolac. For the young aged patient in the teenage group, we should avoid the ketorolac. Okay. And it should not be prescribed for successive 5 days in the oral form. Sometimes in surgery department or in the orthopedic department, it is found, even in our USTs, it is found that it is being prescribed for 10 days, for 15 days to reduce down the pain, as this is the most potent anesthetic. But unknowingly or knowingly, actually, you are putting the patient into the danger. And I think it is common in all the surgery department of all other medical colleges. This is not the unique thing of the USTC, but it happens so. Unknowingly or knowingly, we are going to put the patient into danger. So it should not be prescribed for successive 5 days, because this is the cardiotoxic drug and the renal toxicity will be there with the prescription of the ketorolac. So mind it that ketorolac should be avoided as much as early as possible. Though the patient is coming to you with the severe pain, okay, you may prescribe the ketorolac to reduce down the severity of the pain. Whenever the severity of the pain will be less, so we should switch to other drugs which will be having the less potency, which will be having the less side effect on the heart and the kidney health. Okay, and for the parenteral route, ketorolac should not be prescribed for successive 2 days. We should actually switch over to other less potent and less harmful drugs then and there, whenever the severity will be less, severity of the pain will be less. Okay, you see here I mentioned the NSAIDs in GI safety. First of all, the paracetamol, though paracetamol is not counted that much in all the books within the NSAID, but still in some of the studies, it was mentioned as the NSAID. Actually, this is the antipyretic drug, but still it can be helpful in reducing down the pain in case of the minimum severity of the pain. Okay, and the paracetamol is the safe drug for the gastric mucosa. Next comes the name of the acetaminophen, and then next comes the name of the COX-2 selectives. Earlier, I told you about the COX-2 selectives and the acetaminophen. These are safely prescribed for the peptic ulcer disease along with the pain. And next comes the name of the aceclofenac. This is also safer for the gastric mucosa. And later on, see the diclofenac. These are also less harmful than the ketorolac, naproxen, indomethacin, and the ketoprofen. So these 4 drugs are harmful for producing the gastric mucosal erosion, and ultimately this might be associated with the gastric bleeding, gastromucosal bleeding. So better to avoid this kind of 4 NSAIDs, that is the ketoprofen, naproxen, indomethacin, and ketorolac for the pre-existing gastric mucosal erosion. So I think you got the point about the inside things of the NSAID in GI safety. Okay, I'm going to the next slide. You see, I'm mentioning some of the information about the diclofenac. Diclofenac is safe up to 2 years for GI safety, mind it. We can prescribe the diclofenac for 2 years, okay? And it shouldn't be infused directly in the IV form, mind it. Say a patient is coming to you and he is actually screaming out of pain. You can't give the direct IV injection of the diclofenac. It must be given in the infusion by diluting this in 50 ml of normal saline. Otherwise, the patient will be having the generalized vascular necrolysis. And as a consequence, the patient might die off due to the direct intravenous use of the diclofenac. So these are very important things for you. So I think this is the end of the slide. Thank you. So this actually class is very important for you for your future establishment of the physiatric approach. And whenever you will be doing the GP, general practice outside, actually, if you have this idea about the NSAIDs that I mentioned, about the preference and the potency of the NSAID, I think that will be much more helpful for you in selecting the NSAID and to make the prescription very just for the patients. So I think thanks to all of you. Muntasir, Nafisa, are you there?
Yes, sir.
Yes, sir.
Okay, is there any question from your sides?
I have a question.
Bolo.
Sir, naproxen is the safest drug for kidney among the NSAIDs, and ketorolac and ibuprofen is the dangerous for kidney among the NSAIDs. Sir,
No,
why
no,
want
no,
to
no,
know?
no. I didn't tell like this. So what was your question? Abar bolo. Muntasir.
Sir, naproxen to the safest for kidney.
No, 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 no. Naproxen safe na. Naproxen safe na. Borong naproxen হচ্ছে safe for the heart status. Cardiovascular safety আছে naproxeনের। ঠিক আছে?
আচ্ছা,
কিডনির জন্য সেফ
জি স্যার।
হচ্ছে nabumeton, not the naproxen, nabumeton and the sulindac. Because the nabumeton and sulindac won't interfere in the formation of the renoprotective prostaglandin. But all other NSAIDs will interfere in the formation of the renoprotective prostaglandins. যদি renoprotective prostaglandin যদি না থাকে তাহলে হোমিওস্ট্যাটিক মেকানিজমটা মেইনটেইন হবে না। দেখা যাচ্ছে যে যদি তার রেনাল আর্টেরিয়াল স্টেনোসিসের জন্য কিডনির মধ্যে যদি কোনো ইস্কিমিয়া হয় এবং এই ইস্কিমিয়াটাকে আরো অ্যাগ্রেভেট করবে by the interruption of formation of the renoprotective prostaglandin, and which is aggravated by the prescription of the all NSAIDs. Only the nabumeton and the sulindac won't interfere in the formation of the renoprotective prostaglandin. So that's why these are safer so drug for the kidney health. Is it clear?
Thank you, sir. Yes, sir. Thank you, sir.
Okay, আর কোনো কোশ্চেন? আর কোনো কোশ্চেন আছে?
আমার স্যার আর নাই। Thank you, sir.
Nafisa, do you have any question? Is there any
না
recorded
স্যার,
question?
আজকে কোনো
on the
কোশ্চেন
Facebook?
নেই স্যার। আপনি অনেক সুন্দরভাবে এক্সপ্লেনেশন দিয়া আজকে ক্লাসটা নিচ্ছেন স্যার, খুবই উপকৃত হলাম
জি, থ্যাংক ইউ।
স্যার। কোনো কোশ্চেন নেই
জি,
আজকে।
ধন্যবাদ তোমাদের।
Thank
আচ্ছা,
you, sir.
ঠিক আছে। ওকে, I think I should conclude the session. Okay.
জি
ওয়ালাইকুম
স্যার,
আসসালাম।
থ্যাংক ইউ
ধন্যবাদ।
স্যার। আসসালামু
আল্লাহ
আলাইকুম।
হাফেজ। থ্যাংক ইউ। ওয়ালাইকুম আসসালাম।